Thanks so much for joining me today to talk about the role of chemotherapy in primary brain tumors. So help me to understand that. When is chemotherapy employed?
Yes, so chemotherapy plays a key role nowadays in the treatment of these cancers. It hasn't always played a key role, but we have more and more data that there's a role for chemotherapy in treating these cancers. Some of these chemotherapies are given by themselves, some of them in combination with radiation. The most common regimen that is administered for patients with newly diagnosed high-grade astrocytomas is the combination of radiation and temozolomide. Chemoradiation is the first step of treatment after surgery, which is a combination of radiation with daily oral chemotherapy with the goal of helping the radiation work better. At the same time, the chemotherapy is expected to have its own effect on the tumor cells.
And this is with the agent that you mentioned already.
That's right, with the temozolomide.
How do you decide who's appropriate for that?
So based on the available data in the literature, we would, outside of a clinical trial for standard treatment, we would administer this treatment for everybody with a newly diagnosed glioblastoma who we feel is well enough to tolerate that treatment. Factors like age, comorbidities might play a role, and it's always a personal decision we make. But for the most part, we think there's a clear benefit from chemotherapy, and we help patients make that decision and then coach them through this process, which is often very difficult and new to patients.
Once a decision is made to use chemotherapy, what can someone expect?
So there are different types of chemotherapy. The temozolomide I'm going to talk about is oral. So first of all, it is much better tolerated than other chemotherapy that you might think of. From the temozolomide, you would not lose your hair. From the radiation, you may in certain areas. It can cause fatigue. It can cause changes in your blood counts, which we would monitor carefully with weekly blood counts. It can suppress your immune system because the lymphocytes that are part of your immune system are typically decreased during with treatment with radiation and chemotherapy. It can cause nausea that is well controllable with many medications we have. Constipation is very common, for which we recommend stool softeners and other medications, all very doable.
Could you describe for me a typical course of treatment?
So a typical course of treatment, let's say the quote-unquote textbook treatment for newly diagnosed glioblastoma would be best surgical resection followed by 6 weeks of radiation with daily oral chemotherapy. If that's well tolerated for 6 weeks, including weekends and holidays, 4 weeks of a break, a rest period. This is followed by a new baseline MRI, and then 6 cycles of what we call adjuvant chemotherapy with temozolomide, but with a different dose and schedule. High dose to have the chemotherapy work by itself optimally, 5 days per month, 5 days out of 28 days. And the toxicity is a little bit different, a little bit more nausea, a little bit more fatigue from the chemotherapy, but it's also, again, it's a relatively tolerable chemotherapy if you compare it to other regimens with multiple chemotherapy drugs.
It sounds like you're really optimistic about the management of side effects. How about outcomes?
So a lot of the things we do are based on clinical trials, and also clinical trials that have already been completed in the past that show us how well do these treatments work. High-grade gliomas are not cancers that we, at the present time, unfortunately, consider curable. Our goal is to treat them as well as we can and to improve outcome, meaning survival and quality of life, and reduce neurological deficits over time. That being said, we are optimistic that the trend in brain cancers will follow the trend in other cancers, that we have better and better treatments and that patients will do better and better over time. Outcomes are different for each individual patient, and looking at these numbers in the big journals is sometimes difficult, and we have to be cautious not to extrapolate those numbers and apply them to each patient and just throw around numbers, because they might be we might be completely off, and it might be that patients are doing much better than the average, some people not doing as well as the average. And I think a very good human interaction and medical team building to optimize the care for each patient is what's critically important.
Excellent. Thank you so very much.
Thank you very much for having me.